Welcome back to the Sunday Paper Roundup, back in the UK. Now, this is probably going to be the most controversial video I've ever done. And honestly, it really shouldn't be, but watch it till the end and make up your own mind about why. Last week, I posted a carousel summarizing the evidence behind injections for knee arthritis based on the highest available evidence. It generated a lot of discussion and a bit of emotion. Much of it centered around arthrosamid, so today I want to look at the evidence properly. 3 arthrosamid papers, all recently published. But first, a quick reminder what this series actually is. The Sunday Paper Roundup is a critical appraisal of recently published papers every week. I've always read the latest evidence to ensure I'm fully up to date with my practice, and this series became simply my way of sharing that process with many other people, but it might be a benefit. I look beyond the abstract, read the methods, the statistics, the limitations, the disclosures, and asking one simple question. Does this paper actually change what we should do for our patients? I'm not trying to tell anyone what they should think. I'm simply explaining how I interpret the evidence and why. But let's be clear, the Sunday Paper Roundup isn't me doing a formal systematic review and putting it on Instagram. It isn't a review or meta-analysis of every single paper ever published on our topic. I simply couldn't do that every week. Instead, I just ask one question. Have these newly published papers materially changed the evidence? And that's the lens for today's discussion, and by the end, you can decide whether any controversy is justified. Arthrosamid is everywhere at the moment. It's all over social media. Patients ask me about it every week, but it's not available on the NHS and it isn't covered by private medical insurance. So patients are paying around £3,000 out of pocket themselves for a single injection. So when I see groups in social media posting 100 arthrosamid injections completed with balloons behind them, 200 here, all I can think in my head is, 100 times 3 grand, 200 times £3,000, and do the maths. So when 3 important papers were published this year, I did what every evidence-based surgeon should do. I read them carefully, not because I had a particular answer or viewpoint in mind, but because I wanted to know whether these publications generally strengthen the evidence or whether the enthusiasm had moved ahead of the science. Welcome to the Sunday Paper Roundup, where I read the paper so you don't have to. Paper 1. Let's start with the largest study. This was the first 5-year follow-up of the original randomized control trial. It's important to understand something straight away. Although we're discussing 3 different papers today, the 3-year and 5-year publications are extensions of the same original randomized trial. They're not new randomized controlled trials. Originally, 239 patients were randomized. 119 received arthrosamid and 120 received hyaluronic acid. At 1 year, arthrosamid was shown to be non-inferior to hyaluronic acid. It was not statistically superior, and after that, the comparison stopped. Only the arthrosamid patients continued. Of the original 119 patients, 91 entered the extension and only 58 completed 5 years. Those patients continued to report improvements in pain, stiffness, and physical function, and no new device-related safety concerns were identified. Those are the reported findings, but here's a critical point. By 5 years, this was no longer a randomized controlled trial. There was no placebo group. There was no hyaluronic acid comparison. Patients were simply compared with where they started. So the study can tell us that patients who remained reported sustained improvements, but it cannot tell us confidently how much of that improvement was caused by arthrosamid itself. The paper also reports that patients who remained had significantly better outcomes after the first year than those who withdrew. The authors themselves acknowledge that this may have overestimated the treatment effect. There was another interesting finding. Pain improvement reached statistical significance in patients younger than 70, but not in patients aged 70 or older. The study wasn't designed to prove that age changes treatment effect. The authors discussed several possible explanations, including patient attrition. Again, it's a reminder that the evidence is more nuanced than the headlines. The second paper reported another 5-year cohort. 49 patients were treated, 27 completed 5 years. Again, patients reported improvements in pain and function. Again, there was no control group. And importantly, the authors themselves conclude that arthrosamid may be effective and that further research is required. So this paper gives us longer follow-up, but it doesn't materially strengthen the quality of the evidence. The third paper was the most important for me because rather than reporting new outcomes, it reviewed the published arthrosamid literature as a whole and asked a bigger question. How strong is the evidence overall? And its conclusion was cautious. The authors acknowledge that published studies generally report improvements in pain and function, but they also conclude that the evidence-based trial has important limitations in both its quantity and quality. Only one randomized controlled trial exists. Many studies are small, many are uncontrolled. Patient-reported outcomes may be influenced by placebo effects, and importantly, all published clinical studies investigated the same product from the same manufacturer. The authors concluded that further high-quality studies are still needed before routine clinical use can be recommended. I think that's a balanced and fair conclusion. One thing also became increasingly obvious as I reviewed these papers. Much of the published evidence comes from the manufacturer's own research program. The largest 5-year extension was sponsored by Contura, the manufacturer of arthrosamid. According to the paper's own disclosures, the company was involved in study design, analysis, and interpretation. It prepared the clinical investigation report, it funded editorial and medical writing support, and it made the decision to submit the manuscript. The authors state that they retained responsibility for the scientific interpretations and the conclusions. Now look, industry-sponsored research happens in medicine. That doesn't automatically invalidate a study, but the greater the manufacturer's involvement in generating the evidence, the more important it becomes for independent researchers to reproduce those findings. Scientific progress doesn't happen because one research program continues to report similar findings. It happens when independent researchers can reproduce those findings. Before I give you my verdict, here's my own position. I no longer perform knee replacement surgery. My practice is now entirely focused on sports injuries and knee preservation. Every week I see patients who are trying to delay or avoid knee replacement, so I would genuinely love a non-operative treatment that reliably produced meaningful, durable long-term benefit. If such a treatment existed, supported by robust evidence, I'd be delighted. I don't have an arthroplasty practice to defend. My only interest here is getting the evidence right. One final point: if I've missed a high-quality, peer-reviewed clinical study, not an unpublished poster, please tell me. I'm genuinely happy to discuss and debate the evidence. So what's my verdict? Have these papers added evidence? Well, yes. Have they fundamentally changed the quality of the evidence? No. We now have longer follow-up, but we do not have any substantially stronger evidence. These papers should not be ignored, but neither should they be interpreted as definitive evidence supporting routine clinical use. The evidence base remains limited with important methodological limitations. And after reviewing the current published peer-reviewed literature, I remain unaware of any independent, non-sponsored clinical studies demonstrating the effectiveness of arthrosamid. So here's my view. Extraordinary claims require extraordinary evidence, and permanent implants deserve particularly careful scrutiny. I have ready access to arthrosamid. Patients ask me about it almost every week, but I've not referred a single patient for it, and after carefully reviewing the available evidence, I won't be doing so. Not because I believe arthrosamid has been proven not to work, but because I do not believe the current evidence is yet strong enough for me to recommend a permanent implant inside a patient's knee in good faith. If future high-quality, independent, peer-reviewed research materially strengthens the evidence, I'll happily change my practice because that's exactly what evidence-based medicine demands. But today, based on the evidence we have, I won't be recommending arthrosamid, and just a heads up, I won't be engaging in the comments with statements like, "It works well in my hands," or "My patients are happy," or "I like it." They don't answer any scientific question. They're just clinical observations. They generate hypotheses, but they cannot establish treatment effectiveness on their own. For me, when patients are paying around £3,000 themselves out of pocket, I believe the evidential bar should be high. My responsibility isn't to follow enthusiasm, it's to follow the evidence. Anyway, I'll see you next Sunday. I'll keep breaking down the evidence as it lands.